Welcome to It's Your Health. Philip Benyo with Philip Benyo, bringing you the latest and greatest in healthcare information. Remember, it's Your Health, your leader in healthcare information. Make sure you check with your healthcare provider before doing any of the things that we talk about here on It's Your Health. We'll be right back after this brief commercial message. Welcome back to the first segment of It's Your Health. And before we start, I have to announce that sitting next to me here, my son is the biggest loser. As part of a healthcare, what would you call it? A healthcare promotion that the hospital ran, Lehigh Valley, he lost the most weight of everyone who was involved. And he did that through diet. And of course, he's involved with cross fitness in drums, which went a long way to helping him lose, close to 30 pounds maybe?
Yeah, about that.
About that much. And so...
the point is, I shouldn't have had that much to lose. I have that same problem every year. I can win this and lose this every year.
There you go.
I'll study for the test, and next year we'll announce another winner.
Moving right along.
All righty.
Congratulations, by the way. Congratulations.
All right. FDA approves a new asthma medication made by GlaxoSmithKline called the Arnuity Ellipta.
That's hard to pronounce, but easy to use, right? Once a day, is that right?
That's correct. It's a once-a-day inhaled steroid. And for asthma, the inhaled corticosteroid for daily maintenance is important. And it used to be something we'd have to use twice a day. Sometimes there were inhalers. And some of the newer devices now, as you can see here, are a lot easier to use. Although this isn't the exact medication, this is the same device that you can simply, you pull it down, it loads the dose automatically, you put your lips over it and inhale when you're ready.
Wow, that can't be simpler.
Remember, with a steroid, maybe rinse your mouth out each time you use it so you don't get thrush. Simple stuff.
And make sure you take the breath in real quickly like you just saw a ghost. If you take it in slowly, it ends up on the roof of your mouth.
All righty, moving along. There you go. Flame retardants tied to thyroid cancer risk. Wow. Recent studies have showed some of the flame retardants that are commonly used in household items like furniture and toys actually can be linked to certain papillary tumors in the thyroid.
You know, thyroid cancer has kind of taken a little uptick. Maybe it's our awareness. If you feel something in the thyroid area, which would be right over here, keep in mind the thyroid is like a shield over both sides of your lower windpipe. Get a check and perhaps an ultrasound that can pick things up as well. But we've seen more and more issues with thyroid, and maybe this is one of the reasons.
Yeah, that's a good link. All right, now we're going to move along past some headlines and talk about riveting topic of hypertension. And you know, we've talked about it before, and we've talked about what some of the guidelines and the treatment expectations are, but I'd like to maybe delve into that a little bit further and first talk about, well, what is high blood pressure? What's considered high, and then what are we using to treat that?
Well, if you put too much air in your car tire, the car tire is going to literally wear out quicker than it should. It might explode on you while you're driving. And our bodies are no different. When you have high blood pressure, it puts excess stress and strain on the blood vessels, which leads to premature hardening of the arteries, which leads to stroke and heart attack. Silent killer is how we used to call hypertension. And to some degree, it's age-related. We'd like your pressure when you're our age, around 120/70-ish?
Absolutely.
Lower is better. Lower is better. As we age, we can accept a little bit of a higher blood pressure, but nevertheless, lower is better. And the thing that's I find very frustrating is that it's out there, it's undiagnosed, untreated, uncontrolled, and we have an array of medications which are fairly inexpensive and at work with few, if any, side effects. So it's sort of frustrating to see someone out there with uncontrolled hypertension.
I think the problem is it's asymptomatic. It's not like someone has a turkey timer, they can look down and be like, my pressure's high. They just, if they felt bad or realized they felt bad, or if they had some type of problem that they were aware of that their high blood pressure was causing, I think they'd be quicker to accept treatment for it. But it's something I put around their arm, and I just, to them, I made up a number and said, you have a problem now and you have to be committed to medication and blood work. But you know, it is for real. And the problem is, the damage it creates is irreversible. I can't fix the kidney damage it creates. I can't fix that stroke. I can't fix that heart attack. Once that stuff happens, it's over. We have to prevent that from happening. And the key is really getting that pressure down when we see it high.
And there are both short and long-acting medications that can bring it down. For people that have very high blood pressure that aren't admitted to the hospital, we don't want to lower it overnight. We want to lower it over a few days' time, kind of like landing an airplane.
Mm-hmm. If you get it down too quick, it can actually cause other problems.
Right.
But that being said, it shouldn't take us 6 months to get someone's blood pressure under control. You know, after getting some trial and error of some medications, we should certainly, if someone's in the 180 over 100 range, I want to see within a period of 6 to 8 weeks getting that pressure down to 120 over 80, 110 over 60.
You want a good Father's Day gift idea? Go spend 40, 50 bucks on a good blood pressure machine and give it to your dad or loved one out there. Although it don't have to be your father to get a blood pressure machine, but you get my drift. It can be monitored and should be monitored as an outpatient.
Alrighty, let's move along quickly if we have some time to talk quickly. Again, we've talked about this before, and again, I think it's worth talking about again, is you're seeing more and more what we call Barrett's esophagus. And you know, this is something that we see for people who have heartburn and it's not getting better with the meds, or it gets better, or it comes right back when we stop it. And you know, we're treating with proton pump inhibitors, we're treating with H2 blockers. Talk a bit about the role of the proton pump inhibitor. They have been under fire. We've been reporting more recently about all the problems associated with proton pump inhibitors, but I think it's worth talking about when they really are absolutely necessary.
No doubt, Phil. And too much acid coming up can irritate and aggravate the lower esophageal sphincter, and just like any chronic irritation, be it smoking or sun damage, can cause cancer in that area. And the Barrett's esophagus is considered a premalignant condition, and it's a warning sign that too much acid is coming up to that area and aggravating it. So the proton pump inhibitors are used to decrease acid formation. They're not without side effects. You can get bone loss, and they've come under fire. I think weight loss and watching the things that can increase acid production is also going to be beneficial as well.
Yeah, the key is once we have Barrett's, though, then that's really when you're kind of committed not only to lifelong treatment, but also lifelong surveillance. Because even under best treatment, you know, circumstances, that still can convert itself to something that's dysplastic or precancerous or ultimately cancerous. Now, we don't see that happening very often, but it does happen. And esophageal cancer is not fun. You know, that's one of the cancers that's not really easy to cure and is very devastating.
Again, yeah, keep an eye out for that.
But a lot of times what we run into is people use these proton pump inhibitors because they ate too much pizza and drank too much beer last night and they don't want to feel the punishment from that. So they're going to take a proton pump inhibitor to fix that, maybe cutting back down on the pizza and beer.
Lifestyle modification. We're going to be right back after this brief commercial message. Remember, you're watching It's Your Health, your leader in healthcare information. We'll be right back. Welcome back to the second segment of It's Your Health, and we have a photo quiz out there for those that like to be detectives. The answer to this rash is actually in the picture. What do you think there, Fipster?
This is pretty neat, and you got to be a pretty good sleuth to pick up on this because it's not a place we see it very often. This gentleman probably doesn't tuck his shirt in very often, and as a result, that belt buckle is probably doing some rubbing, and I'd be willing to bet that belt buckle is not a piece of solid brass or a piece of solid silver. That's probably something made from nickel.
Right. Nickel allergies. We see this fairly common because some people will get their ears pierced, for example, or have a necklace, and they'll get a rash that's kind of close to that area of interest. So if you have a rash that doesn't go away and there's metal next to it, the good bet is that it could be a nickel-induced allergy. Can you comment a little bit more on nickel sensitivity?
Well, it's becoming more common because we're exposed to it a lot more, and I think we're sensitizing ourselves. I think one very unique case I've seen of nickel allergy is someone who had some low back surgery, and about a year after their back surgery began having chronic rashes all over the body, itching, nothing specific. You know, they had some allergy markers up, and it turned out that that person had a nickel allergy that they kind of knew that they had. but did not realize that the hardware they put in her back had nickel in it. And at the time, they didn't even realize that, so they had to take that hardware out. And as soon as they had that hardware out, within a month, her rash went away, and she had that for over 2 years.
Wow.
And so it is certainly common. It's something to look for in areas that you're exposing nickel.
Well, we're going to have a little role reversal here. I'm going to ask the Fipster here some questions, since part of his bailiwick, is that the right word, is fitness and exercise. So here we go, Fipster. I don't have too much time to exercise, so I can't. But would taking the stairs, for example, count?
Well, yes and no. Is it better than the elevator? Yes. I hear that a lot. Someone will say, well, I have a busy job. I walk 3-4 miles a day at work. I said, well, you're still 50 pounds overweight, so that's obviously not working. The key is that exercise has to be vigorous. So we're looking for 150 minutes of moderate exercise a week and up to 75 minutes of vigorous exercise a week. Now, moderate exercise is not the type of exercise you and I can have a conversation with. We're going to be huffing and puffing. Vigorous exercise, I'm not having a conversation with that. Now, it doesn't have to be 75 minutes all at once. It has to be divided throughout the week. So you have to exercise 3-4 times a week. And that's what really counts, is putting in that type of time.
Well, I used to exercise quite a bit and jog, but I didn't do it because at the end of the day, I found I couldn't sleep. So does exercise late in the day cause insomnia?
For the most part, no. But sometimes it can, depending on the type of exercise you're doing. If you're doing exercise that you're actually releasing endorphins, so if you were getting that runner's high and you're releasing adrenaline or endorphins, or you're doing a real high-intensity training and you're releasing endorphins, sometimes they can kind of stimulate you and wire you up. That being said, some people exercise within a few hours of going to bed and don't have any problem. A lot of people actually look forward to exercising early in the morning because it is like a cup of joe. It helps wake them up.
I thought you'd get me off the hook there, Phil. Thanks. Last question, Fipster. Exercise, the cellular fountain of youth.
Yes. So what is the fountain of youth? You know, we've talked about pills, we've talked about potion, we've talked about testosterone, but really the fountain of youth is high-intensity interval training. What is that? That means intense bursts of intense activity. And so the best example of that was invented by a doctor in Japan by the name of Dr. Tabata. And so we actually call it Tabata exercise. So that's where you exercise for a very short period of time, say 20 seconds, and then you have 10 seconds of relative rest. Then 20 seconds of intense exercise, 10 seconds of relative rest. So what is that? That's 20 seconds of, say, biking on an exercise bike as fast as you can, and then you get to rest for 10 seconds. Then you get 20 on, 10 off, 20 on, 10 off, and you do intervals of that. Or you switch it up, where you do intervals of as many air squats you can do, or push-ups you can do, 10 seconds off. And then the next thing is lifting something up as fast as you can, 20 on, 10 off. Sometimes the intensity is so high, you do 10 seconds of intensity and 20 off, but you cycle through that for a period of 8 to sometimes 10 minutes. You know, that's 10 minutes of exercise. Who doesn't have 10 minutes to do exercise? You will be half dead doing a high intensity workout if you do it correctly. And that's really the key. And that's, you know, people ask, well, what is my goal in life? My goal is to be 80-year-old, you know, and be able to, you know, sit in golf, drive a fancy car, and chase women at the country club. You know, that's people's life goal. And the way to do that is not going to be eating like junk. Okay, it's not going to be you know, going for a light jogger here. It's going to be this high intensity interval training. That's what's going to get you to the point where, if that's your life goal, this is the way to do it.
Good point, good point. Moving right along on exercises, one of the things we worry about, of course, is injuring yourself. And so I'm going to go through a list here of things, Phil, that are common injuries, and perhaps you could comment on them and maybe how to prevent them. ACL injury. The ACL is the collateral ligament in your knee, right?
The anterior cruciate ligament, a very important stabilizing ligament. This is a very common injury. We hear about this a lot. It's more common in women, especially younger women. We see this as a softball injury or sometimes a soccer injury. The real key is just knowing that certain people are at risk for that, is also to perform certain conditioning exercises and strengthening exercises to help stabilize that joint, and to know that we have to be careful with loading these type of joints in the people who are more at risk for this injury.
How about heat illness during this time of year when it's starting to get warmer and people are exercising?
Absolutely. You have to be careful. If you know it's going to be a hot day, know that you're drinking plenty of water if you're going to be out there, that you shouldn't be exposed to the sun for long periods of time, especially if you're not used to it. You know, days that get nice and warm, people are going to say, they're going to watch this show and they're going to go out and it's 80 degrees and say, well, Phil said high intensity interval training. I'm going to go outside and I'm going to run as fast as I can for 20 seconds and stop for 10. You're going to get yourself in trouble fast. You really have to stay hydrated, stay slightly shaded, but make sure you're wearing clothing that's loose enough that you're able to cool off.
Yeah, and watch the energy drinks and alcohol.
Absolutely,
by the way.
big part of it.
Alcohol. How about things such as sprained ankles?
They're also very common injuries, more common in sports like soccer and softball, where we have twisting and turning, as well as football. For people who have had those injuries before, sometimes they need to wear a brace. A lot of times, using isolation exercises to help build up the strength on that side, you can actually stabilize that joint by providing better musculature around it to work on your balance and coordination so you don't get these injuries in the future.
Yeah, one of the exercises I used to do is you cross your legs and put your wife's purse over the top of your foot and go up and down, and keep weighting it, and that tends to strengthen the ligaments. I was thinking of strengthening ligaments, another fast half hour here in television history. We're going to be right back after this brief commercial message. Remember, you're watching It's Your Health, your leader in healthcare information. Be right back. Welcome back to the fastest 30 minutes out there in television land. It's Your Health. I'm with the Fipster, knows all, sees all, and is telling all right now. So let's tell all about some more headlines there.
All righty. Wider utilization is needed in the treatment and prevention for stroke and heart attack in diabetics. And what is the number one way we do that?
Statin.
That's right.
That's right. Underutilized statins. I understand diabetics, they say, what, one more pill? But nevertheless, that's probably the more important one to take. A statin will lower the bad cholesterol, hopefully cut down on the inflammatory response that diabetes provides, and will lower one's risk of stroke and heart attack. It's really the cornerstone of treatment of diabetics.
Like, when have you heard of someone dying from diabetes? You don't hear that. You always hear stroke and heart attack, and really statins are the only way we're going to really prevent that. Good blood sugar control is certainly important, but stroke and heart attack is still not far behind.
Right.
All right, let's move on. Something a little bit different. We've talked about this word. We mentioned this probably a few years ago. One of those, you heard it here first. Well, you're going to hear it here again. But what you're going to hear here first is we actually have a biomarker for it. Looking for sarcopenia. Let's briefly describe what sarcopenia is again.
Well, penia means less, and sarco is muscle. So it's someone who has not much in the way of muscle tone or has lost weight, and with that has lost muscle. Now that's very important because that means you're debilitated, you're a fall risk, and you're someone who's going to sit around more and get more sarcopenia. And so how do we find that out?
Well, in the past, we would just identify someone losing weight, and we used to applaud it at first and say, wow, you're losing weight, that's great, but it's not necessarily maybe losing the right weight. But losing muscle mass certainly is a problem. And they've actually done some research to look and say, what's the best way to look for this? So certainly doing muscle mass index and all different types of measuring is possible, but that's difficult to do. It's not feasible to do in an office setting. And so some researchers looked at something very simple, something we test for probably every 3 months, and that's serum creatinine. That is a basic kidney function marker we use. But serum creatinine is actually made in your muscles rather constantly, all the time. 90% of your creatinine comes from muscle production. If you have less muscle producing creatinine, your creatinine is going to be less. And so every now and then we'll run across some blood work that shows someone's creatinine is actually low. Well, what did that mean? In the past, it really didn't mean anything to us, but now actually it's something to think about. Well, why is it low? Is it low because they have a problem? Is it low because they're muscle mass? Maybe that's something we have to use as a marker.
Right, now it's the whole point. So creatinine, of course, is a biomarker for renal function, and we get worried when it goes high. But in this particular case, if it's too low, that means you don't have the muscle to make it.
And there's some things that can false positive and false negative that we can look for. But certainly, I know I'm going to keep my eyes open. When I see one that actually lists it as low, I used to not really consider that a problem, but maybe I need to look at that further. Moving on again with our in our more geriatric section, I get a lot of people will come in and say, geez, they're in their 60s and they're starting their memories, thinks they're going, and they're like, I'm worried about early onset Alzheimer's. And let's briefly talk about what that means in the incidence. Early Alzheimer's is actually relatively rare. I think it's less than 1% of all cases, but what do we need to look for?
Right. Well, before the age of 65, it would be unusual, but not unheard of. And I think the big thing is looking back at your parents, because this is an inherited disease. So if your parents or grandparents had early cognitive issues, memory problems, or Alzheimer's, that puts you unfortunately at risk. Obviously, I would get a examination because there's reversible causes of dementing illnesses. For example, B12 deficiencies, depression, low thyroid states. And we have screening tests that could tease out, who's who and sort of identify who's at higher risk. I think the key, however, is having someone in the family identified, because the average person won't come in with a sticker on their head saying, check me for an early dementing illness. The closest one, wife, spouse, son or daughter, is the one who drags them in and says, we see a personality change, what's going on here? So that's key. You gotta kind of turn these people in.
Yeah, usually if you're worried about having it, you probably don't. I have a lot of people come in and say, oh, I'm worried I'm getting Alzheimer's. And it's generally, if you're concerned about it, you probably don't have it, because the people that don't realize it's happening are the ones that, unfortunately, it's happening.
That's a good point.
So for a moment, and I think this is something really important to talk about caregivers, because, these patients who do have Alzheimer's, and not necessarily early onset Alzheimer's, just the whole array of Alzheimer's, there's many different caregiver issues. And so I think it's important to kind of talk to the caregivers to say, how can you be prepared for when you come for an appointment? What do you need to think about? What are some of the challenges we have to meet?
Well, unfortunately, with someone caring for someone who has a dementing illness, it's almost like having a 5-year-old on your hands, an adult 5-year-old, because there's issues of trying to take care of themselves, there's self-care deficits, there's hygienic problems, there's fall risk, there's wandering, there may be behavioral issues, and as I sometimes tell families, that the patient is going to bury them, because the caregiver is at tremendous stress and will just get worn down. So they really need a lot of help, and they need a lot of family support in order to deal with this.
All righty, let's move on. Lastly, what do we have here? You see a picture there. Do you ever see these?
I've seen this a couple of times. This, believe it or not, is someone's foot, and those are nails that are growing out. Don't see it too uncommonly. I know that looks kind of gross, but nevertheless, we see this in someone who have self-care deficits.
Right. Now, you do a lot of home visits now, so this isn't someone who's obviously doing a lot of weight bearing or getting out in the world. They certainly couldn't put a pair of shoes on, but it certainly exists and creates a lot of problems. Sometimes when we admit someone to the hospital, we'll take the sheets down and, oh my goodness, look at this. We have to get a podiatrist to come in and cut their nails. And that's actually not uncommon. And certainly these are they're pretty up there as far as the Hall of Fame nails, but we've seen half of that all the time.
Yes, and the nails, of course, keep on growing whether you're walking or not. And these kind of nails would keep you from walking more. So
absolutely.
You end up chasing your tail, and it's almost a continual problem there. Moving right along with gross pictures, how about we show you what looks like what, Phil?
That's pretty neat. This patient came in with unilateral or one-sided throat pain, severe throat pain, and they're having a hard time talking, and it's not just the usual sore throat. And you open their mouth and you're looking, you're like, oh my goodness, you see this swelling all one side, it's pushing their whole throat over to the side. Real spooky stuff, and this is something we don't see very often, but it does happen. It does happen here in town with some frequency, and that is?
Peritonsillar abscess. The tonsils can get abscessed, and it's just one gigantic pimple where it doesn't belong, especially in your throat area. Usually this needs hospitalization and maybe a needle stuck in it, drain it, and antibiotics.
Yeah, abscesses don't clear up just with pills. You know, they have to be drained. And so, yes, is that a needle in your throat? Absolutely. It is a needle in your mouth, and that's usually accomplished by an ear, nose, and throat specialist. That's certainly something that we're not going to tackle down
Our
here.
pay grade doesn't cover that.
Absolutely not.
But our pay grade does take care of taking care of you out there in television land. Thank you for joining us for yet another edition of It's Your Health. Remember, your leader in healthcare information. Hopefully we've entertained you and informed you along the way. Happy Father's Day to fathers all out there, and thank you for watching.